The STP model helps to optimize the diagnosis and treatment of sexual disorders. Narrated by Dr. Michael Perelman. Good sex therapists ask about sex in minute detail while maintaining rapport with their patient. When taking a sex status, the clinician asks probing questions, steps back as needed, then tries asking for more. The timing all depends on the patient's comfort level. Always try to identify key details about sexual friction, frequency, and fantasy in order to optimize treatment planning. Re-examining sex status at follow-up provides guidance for treatment alternatives if an initial intervention is insufficient. What theory can guide those questions? The answer is the sexual tipping point model. The STP shows both the mental and physical elements of male and female sexual function and dysfunction. Why is that important? Sex is more than just biology. Sexual response is an endpoint representing the sum of every thought, behavior, relationship, and cultural factor, affecting an individual at that critical moment. Of course, this mind-body concept is older than Descartes. Why? Because sex is always mental and physical. The mind can turn you on, and the mind can turn you off. The body can turn you on, and the body can turn you off. Positive mental and physical factors increase sexual response. Negative mental and physical factors inhibit sexual response. Good blood flow is hot. Cardiovascular disease is not. Sexy thoughts are hot. Performance anxiety is not. Yet all this is not binary. So many patients ask, is it just in my head or is it medical? It's always both, just to a greater or lesser degree. Dual control models explain such complexity. My mentor, Helen Kaplan, published this sketch in 1995, a few months before she died. We use that model of sexual motivation to discuss organic and physiological sexual inciters and suppressors. Helen's passing inspired my expanding her work into the sexual tipping point model. This is what we now teach at Weill Cornell. Young doctors learn that sex is a biopsychosocial, behavioral, and cultural response. Sexual disorders have various micro and macro, predisposing, precipitating, maintaining, and contextual factors, which trigger, reinforce, or worsen the probability of their occurring in any sexual encounter. Some years ago, at an international neurobiology meeting, I explained the sexual tipping point model to my friend, the distinguished brain researcher, Dr. James Faus. How good health plus sexy mental and physical stimulation can result in sexual excitation, whether from the caress of a lover, a sexual fantasy, or a sexual pharmaceutical. Yet numerous mental and physical factors can also tip the balance, inhibiting sexual response despite such stimulation. Jim wrote about the STP model in his classic 2009 Journal of Sexual Medicine article on the neurobiology of sexual desire. He describes it as Perelman's seesaw model. Jim speaks of the brain's excitatory systems, how brain signaling by dopamine, norepinephrine, oxytocin, melanocortins stimulate and enhance sexual arousal, and how other transmitters like serotonin, opioids, and endocannabinoids can inhibit and satiate sexual response. This same knowledge about altering brain chemistry to turn on or turn off sexual response is the basis of many sexual pharmaceuticals. Yet, sex is more than just biology. The original manufacturer of the female sex drug, just approved by the FDA, created this video animation using Jim's theories and the sexual tipping point model. The animation illustrates flubanserin's mechanism of action to explain how that drug can help a woman recapture her sexual desire. How does the STP explain all this? There are 4 containers on the balance beam scales. They hold all known and unknown mental and physical factors that regulate sexual response. Each container holds thousands of mental and physical factors represented by the circles, which are sex positive, sex negative, or not. The size of those circles reflect that specific factor's impact level or valence. In this case, valence is a function of genetics or epigenetics or life experience. Yet there are also those factors yet to be identified by science. The STP model accounts for them as well. Some are mental and some physical. All of these unknowns, whether positive or negative, whether hot or not, are represented by a question mark. So an individual sexual tipping point is shown against a normal distribution curve, dynamically representing how their sexual response is hot or not at any moment in time. All this leads to best practices. So how might this apply to real-life folks like you and me? Pictured here are obese men, all of whom suffer from metabolic syndrome. Their risk factors predisposing them to erectile dysfunction might include diabetes, high blood pressure, poor lipids, etc. Typically, Fat David's doctor would give him a PDE5 like Viagra, Levitra, or Cialis. Often this helps. But research also shows that 50% of the time it does not. What to do? Fortunately, we can almost always heal this patient by using an integrated treatment based on the STP model. That might include weight loss and exercise, office counseling, or a sex therapy referral, a PDE5, or a new drug in the future. It might be many of the above, as well as the hand of God. This is the ideal solution to balance risk and benefit. No doubt, new medical treatments will be brought to market and advertised to the public. But we must always remember that sex is more than just biology. The sexual tipping point model makes that clear and easy to understand down to the molecular level. Future treatments will create new questions. The sexual tipping point model has a role in that dialogue. For those who are interested, copies of this video and related publications and presentations are all available free online at mapedfund.org. Thank you.